Hello, everyone. My name is Justin Rist, and today I will be presenting my project on evaluating Medicare dental coverage expansion alternatives. First, let me provide a bit of background on this project. So currently, Medicare, which is retiree insurance that is federally funded by the US government, does not provide any dental or eye coverage. Many Medicare beneficiaries seek out this coverage by paying out of pocket to private dental insurance companies. However, this is prohibitive for many low-income Medicare beneficiaries as it is expensive. The US government is considering expanding Medicare coverage to include dental and eye care for all beneficiaries. This is estimated to cost $358 billion over the next 10 years, and 238 of that specifically would be dental insurance. The American Dental Association somewhat surprisingly opposes this expansion plan. Instead, they propose an alternative plan that would provide dental insurance to Medicare beneficiaries that are below 300% of the federal poverty line, and that line in 2018 was $12,140 per year. A little bit more detail about the two plans. So the plan proposed by the government, the rationale behind it is that it would increase dental care access to the elderly in the United States, as 50% of Medicare beneficiaries currently have no dental coverage, and 49% of those that do not have dental coverage have not seen a dentist in over a year, so they are likely to have bad oral health. The American Dental Association plan proposed reduces the coverage to only those below 300% of the federal poverty line. And the rationale for this is that many dental practices do not accept federal dental insurance plans currently, because the reimbursement rates for those with federal insurance is very low, and it doesn't cover the cost for the dental practices. Many dental practices do not have electronic records, which are required to accept this insurance. And because of these two things, even if this policy were to increase the demand for dental care of this insurance type, there would be limited adoption by dental practices. And this leads into my other consideration on the bottom left of the chart there. Currently, Medicaid beneficiaries, which are low-income families in the United States that receive federal insurance, do receive dental coverage from the US government. And if demand for this type of dental coverage that is federally funded would increase due to expansion, then it's likely that these Medicaid beneficiaries would be crowded out of the dental care market because the slots available for their dental care would be taken by Medicare beneficiaries that gained coverage. That leads me into my problem for this project. And that problem is, what is the best dental insurance expansion plan? The three criteria I will use to evaluate alternative plans is the minimization of travel distance to receive dental care, specifically for Medicaid low-income beneficiaries, as they're least likely to be able to travel long distances for care. The second criterion is to maximize the number of Medicare patients that gain dental care so that more elderly in the US go to the dentist. And the final consideration is to minimize the federal expenditure for whatever plan is adopted, as it would be more likely to pass by the US government. The plans that I considered in this study are the current state of the US insurance market, expansions of dental insurance to include populations at 100% or below, 200% or below, 300% or 400% of the federal poverty line. Included in there is the 300% recommended by the American Dental Association. And then finally, a blanket expansion plan for all Medicare beneficiaries proposed by the US government. To evaluate these different plans, the data sources that I used were all taken from 2018. I specifically chose 2018 as this was the most recent year unaffected by the COVID-19 pandemic, which had a large impact on the number of people going to the dentists. The first data set I used was the Medical Expenditure Panel Survey, which is a longitudinal study, meaning it is taken over the course of a year following US citizens, and it includes information from these US citizens such as dental insurance type, the dental care usage, the age of the respondent, income level, and sex information. And in the survey, there was over 30,000 respondents and over 1,500 answers per respondent. So it was a very large data set. Additionally, I used census county population data, and I also used the Health Resources and Services Administration area health resources data. This data was used to estimate the supply by county for dental coverage or for dental care, as it has the totals for how many dentists practice in each county of the United States. Here is a flow chart detailing the methodology that I use for my supply and demand estimations. I first took the 2018 MEPS data and fit a multinomial logistic regression model. I used that model to estimate the demands by county for dental coverage in the United States, using the model and estimating with the US Census population totals. I also took the supply total, the dental count totals, and estimated rates for how many patients each dentist can see in each county per year to get the total supply by county of dentists. And I compared these two values, the supply and the demand, to reach my conclusions. A little bit more information about the multinomial logistic regression model. I chose this as I had my target that I was trying to estimate was the likelihood of a dental insurance type. And there were 4 different dental insurance types that a person could potentially have. A typical logistic regression model is only predicting for a binary probability. So a 0 or 1, 2 categories. However, I had more than 2 categories. So multinomial logistic regression allows you to do a similar type of estimation, except for more than 2 categories. The target, as mentioned, was the dental insurance type, and the predictors that I used were age, sex, and poverty level, as these were both available in the MEPS and the US Census data. As you can see in the bottom left of my screen, that was the results I got for validating that the model was accurate. And as you can see, there's very minimal error in prediction category totals as compared to the magnitude of these categories. To estimate demand and supply, I recommend pausing the slide and looking into a bit more detail about my calculations. And finally, let me get into the results and analysis for my study. The main columns of interest related to the criteria I detailed earlier in this presentation are columns 1 and columns 3 of the table you can see on the screen there, and the charts beneath are those same columns. The objective for column 1 was to minimize the percentage of Medicaid patients that have to travel a long distance to receive care. I considered a long distance across county lines. And as you can see, this value increases only slightly until you get from the 400% poverty level plan to the blanket coverage policy level plan. And it jumps dramatically at that point, which is very bad for our criteria 1. Criterion 2 is shown in column 3 there. And the objective of this criterion was to maximize it. As you can see, this value steadily increases across the range, again, before jumping between the 400% to 100 to blanket coverage plans. However, I'll note that the 53% that gain coverage between 400% and blanket would be the 53% most wealthy Medicare beneficiaries. And these beneficiaries likely can already afford dental care, so it would have minimal impact. The last thing I'd like to point out on this slide is that if the blanket coverage plan was enacted, then there would not be enough supply available to satisfy the dental demand, even if all patients were willing to travel as far as possible to receive this care. That gets me to my conclusion for this project. What is the best dental insurance expansion plan? I recommend that dental insurance should be expanded for Medicare beneficiaries that are below 200% of the federal poverty line. I recommend this plan because it only requires about a 2% increase in travel for Medicaid beneficiaries, so they are not harmed very much at all by this plan. Additionally, there's a 20% increase in Medicare beneficiaries that get dental coverage. And this 20% would be allocated to the poorest 20% of Medicare beneficiaries, which are the ones most likely to be unable to afford dental care. And finally, this plan would not be near as expensive as the quoted plan at the beginning of the project, and it would be much more likely to get passed by the US government. This concludes my presentation. I thank you so much for your time.